Thank you. So I don't know if I need to actually go through much, since the last two slides from Dr. Van Kutsum essentially just support my whole discussion. But just because I need to talk to you for 12 minutes, I'm going to do that. So I mean, the most important thing is when you see a patient in clinic is to understand whether those patients are liver limited and whether patients are potentially resectable. So put them in the basket of potentially curative versus palliative intent. It all depends on the extent of the disease and the tumor burden and the limitation to organ, liver, lung, or peritoneum. There are a number of regional hepatic therapies in the management of colorectal cancer, liver metastases. Some of them are supported but by some data. Others have no data to them or minimal data. Nonetheless, a lot of these modalities are being used. Of course, we're going to focus on that little red box with the radioembolization. I know Dr. Van Kutsum talked a little bit about the role of RFA through the clock study. That's a completely different patient population, different study. I'm not sure it reflects much what we would do with CERT. So the data with yttrium-90 in patients with liver metastases, as you know, yttrium-90 has been used for quite a while, and a lot of it has been actually depending on retrospective analysis and that small randomized study that did suggest that there may be a benefit for a select number of patients. But nonetheless, most of the data that led to the SURFLUX study was mostly retrospective or small analyses. Good efforts, though. I found this actually to be very interesting because it literally tells you who are the patients that are most likely to have control in the liver. And this is actually a paper that was published in 2009 and looked at 4 prospective trials of essentially radioembolization plus chemotherapy and really focused on the blue. And the light blue is first-line progression in the liver. The dark blue is first-line progression in any site. And you can see that the lower part is actually baseline tumor volume. So if the liver is between 10 and 40% occupied by tumor, you're more likely to have control in the liver versus other sites. But if actually it's less than 10% or more than 40%, you don't seem to actually do much benefit to those patients by applying a local control to the liver. And then comes SURFLUX, which is, again, I'm not going to go through the design. Dr. Van Kutsum summarized this really well, but it's essentially the study with FOLFOX plus bevacizumab plus minus SIRT. And again, this was the design, and for the CERT arm, the dose of oxaliplatin was lower for the first 3 cycles, and the 4th cycle, the dose went back up to 85, and bevacizumab was initiated. I think very importantly from the demographics, you can see essentially that most patients had less or equal than 25% tumor involvement in the liver, and the rest more than 25%. So I think it's safe to say, although it's a bit of speculation from this, but it's safe to say that most patients would fall between then the 10 and the 40% that I've just shown you that would benefit mostly from local control. And that, it wasn't surprising then to see that progression-free survival in the liver was higher with the application of CERT to FOLFOX bevacizumab. But this was not the primary endpoint. This was a secondary endpoint. The primary endpoint was negative, was progression-free survival at any site. And so this study is essentially negative. And because it's a negative study, regardless of that exploratory endpoint, should be taken as such. And unfortunately, this does not change the standard, which is essentially chemotherapy plus a biologic in the first line. We are eagerly awaiting, as Eric mentioned, to have the Foxfire study be done. It has actually a primary endpoint of overall survival, which is more relevant. And it actually has a shared statistical analysis with SURFLUX. Now, the whole argument of, let's control the liver disease, because if we control the liver disease, patients are going to live longer, because most patients die from liver metastases, I think is relatively flawed. And because liver metastases and metastatic colorectal cancer that do lead to liver failure and death is only seen in 20 to 25% of the patients, and that's prior to modern chemotherapy. This is in the day when we only had 5-FU. So today, with modern chemotherapy, it's less likely for patients to die from liver failure. In fact, there was an interesting study from Sweden looked at 95,000 patients with colorectal cancer, albeit not the highest impact paper, but I thought this was pretty interesting. Looked at 95,000 patients, 63% died from their cancer, and most actually died from other factors, which is what we see actually in our patients. Unfortunately, they die from competing causes such as pulmonary embolism, bacterial infection, bowel obstruction, etc. So non-liver directed causes. So salvaging the liver per se or delaying progression doesn't necessarily translate into an improved survival. Add to that there are toxicities, and just for the sake of argument, 2% of the patients actually had toxicities in the exact organ that the SERT is supposed to salvage or help delay progression into. Now, there are a number of toxicities that come with radioembolization, and I'm not going to go through the whole list, but I'm just going to lead you to look at in the lower component is careful microcephaly application, careful dosimetry, careful this, careful that, and that's important. That is a question of access. So if we want to make the argument that this should become part of our standard in the first line, the access is going to be extremely limited anyways, because you have to be very careful on where it's done, at least in the United States that's very relevant, where it's done and who does it, because it does come with its own set of toxicities. But let me go beyond that. So do we really need to add a modality such as SERT to the doublet plus a biologic? Can we actually get a liver response rate with systemic therapy alone? And I'm actually going to use a study from Dr. von Kutzem, as an argument against actually adding SERT to FOLFOX plus bevacizumab. This was FOLFIRI-cetuximab, and when looking at the liver-only patients, when we look at the response rate, it's 70.6% higher than the overall response rate, which means with FOLFIRI-cetuximab in the RAS wild-type patients, you can have a much better liver response, and we know that that improves the resection rate, and we know also that that improves progression-free survival and overall survival. So that by itself, I think, would make an argument that this is already a regimen that improves survival and progression-free survival and response rate in the liver. And we don't need to actually add a SERT element to these regimens. And more so, when actually we look at triplet regimens, so take again the same FOLFOX plus BEV and add to it irinotecan, and again, you get a better response rate, you get better progression-free survival, you also get improved liver response rates and resection rates. And again, we know that these modalities do improve overall survival. So I think the conclusion is radioembolization of colorectal cancer, liver-limited metastases is not ready for first line. In fact, SURFLUX is by all means right now a negative study. Primary endpoint is negative. There are cost considerations and, of course, toxicity considerations. And as I said, limited access because toxicities are more likely to happen in those sites that are less equipped to do it. In terms of survival benefit linked to progression-free survival, a negative progression-free survival is typically linked to a negative survival for the most in colorectal cancer. But let's even assume that the argument holds that delaying progression in the liver would improve survival. The only way we're going to know is hopefully get the results of Foxfire and others rather than actually call the lady with a crystal ball to guess for us. So I think at this point of time, we can safely say that SERT is not ready for first line. And with modern therapy, including more aggressive chemotherapy, death from liver burden is less likely, which makes this even less likely to change the standard. I'm going to give Dr. von Kutzem this. There may be a small subgroup of patients that may benefit from the addition of SERT. But at this point of time, it is not well defined, and it's unlikely to become an expanded application. Thank you.